Okay. Bonjour. Bonjour tout le monde. It's a great pleasure to be here. I have to do something with the Zoom because I'm getting my own translation in French. Sorry. I'm sorry that I can't deliver my speech in French, even though I did spend many years in Montreal. As Eric said, I immigrated from Greece, so my French isn't really as good as it should be, but neither is my English. So we'll do the best. I'll do the best I can to communicate my presentation this morning. It's wonderful to be back, and thank you so much for inviting me. We worked very closely, team of us here, Jessica, Eric, and others, Sonia, during the 2009 to 2014, during the 5 years of the At Home project. And so it's been a while, and I'm happy to be back because I have, in that time, since that time, there have been some really significant changes in Housing First, especially internationally. And we have begun to see the end of homelessness. You know, that actually, if we adopt a model and persist and resource it properly, we can actually end this thing, which is really exciting because before any one country could do that, it's just theoretical, you know, but now it's actual. You know, people are doing it at the city level, at the county level, at the program level. And my talk is really about that. It's about, how do I move the slides forward? Okay. Okay, so this is my outline. I'm going to talk about what Housing First is, because one of the things that's happened since this program has been so widely disseminated is that the definition of Housing First has drifted, and lots of people may be calling programs Housing First, but is it really Housing First? And so I'm going to cover the definition, you know, for the first part of it, and go over what are the core principles and practices of the program. So when we're talking today about the Housing First program, we all understand the same Housing First program. And then I'm going to talk to you about what we've learned about the challenges of the program. It's kind of simple to say you bring someone from homelessness into housing, but as many of you know who work in these programs, it's quite a complicated job in many ways. And there are some consistent patterns in which it's complicated, and I'm going to cover that. I'll talk about effectiveness and systems change. So what do we, and then, you know, at the end of the talk, we'll have a break, and then we'll have lots of time for your questions and answers. So as you're you know, if I'm saying things that are not clear or that you want to comment on, please jot them down. You'll have lots of opportunity to ask them, both for the people here, and if you're watching on Zoom, you can write in the questions on the chat. We'll address them all. So what do we need? What do we need to set up a Housing First program? We need 3 components. The first one, of course, is the housing component. And the housing component varies quite a bit from place to place. And so the key characteristics of the housing should include these things. You know, I think when we talk a little bit later about program fidelity, you know, what is a Housing First program? There's about 40 items. It's like a checklist. And you have some of these things or a few of these things. You know, do you have 20 out of 40 or 30 out of 40 or 40 out of 40. I haven't yet visited one program that has 40 out of 40, including the ones we operate. So it's an ideal of how things should run. But what we do find is that the closer you are to a housing first approach, the more effective is the program and the better your outcome. So that's why, we want to define it in a way, because it's all about getting the good outcomes. So we want housing that is, it's called housing first for a reason, because you want immediate access to housing. But what is immediate? It's not today, but is it 2 weeks, or is it 2 months, or is it 6 months? So the immediacy matters because it builds a bond of trust between you and the people you're working with. The housing typically that is most preferred is the one that the client chooses. What is the best kind of housing? The one that the client wants the most. So we get into a lot of debates about housing. Should it be social housing, community housing, rental housing, integrated housing, group housing? It should be the housing that the person feels like where they are most at home. Most people want a decent, affordable place of their own to live, private, secure, and you can, even if you haven't asked them, you can anticipate, because we've been doing this for a long time, that's typically the housing type that will be most requested. So when you're setting up the program, you can be sure that that's going to be the most likely offer accepted by people. And this is not about housing that is, there's a lot of models now being pushed both here and in the United States, tiny home villages, freight cars made into housing, all of these little communities. I don't actually include that as housing, even though some people may choose it. We don't know what the effectiveness of that is. We don't know how it'll play out in terms of the people we're working with. People who are on the street will accept a tent. They'll accept a tiny house. It's not that they won't be filled up. But if we're talking about a model, what is housing first? It's not really housing that is made less than the housing that you and I live in. Something has a lease, you have tenant rights, and it's yours. The service component is also the second major component, and that's all of you. And in fact, that's the major focus of the program, is all about the way that services are provided to people. Most of the Housing First programs provide services that are separate from the housing, community-based. They are typically case management teams or interdisciplinary teams. They have no contingencies. It's a harm reduction approach, so that the engagement is accepting people where they are, but not leaving them there. You want to help them move to the next step. It's it's available as much as possible. I know that varies with staffing patterns, but ideally, you want to have a program that has enough staff so if clients are calling, there's someone there to answer the phone around the clock, ideally. But there is a great deal of coordination that goes on in between a Housing First program and other programs in the community. And so the team that's providing the support needs to also pay attention to that. So the separation, the on-call, the continuity of care, and interdisciplinary is preferable, but it's not the only way to do it. The structure of the team is the same everywhere you go. They are off-site and they are case management or interdisciplinary teams, but the staffing that is on those teams varies from place to place, depending on who you're serving, what population you're serving, and what culture you're in. So if you have a program that is a support staff for people who are young, you would have more youth-oriented staff. Your services would be more towards education and employment than if you were serving, for example, an indigenous community where you might have not a doctor or a nurse, but you might have an elder or people with lived experience, or a culturally appropriate match between the people that you're serving and the people providing the services. So that's open. And I think one of the reasons that the program has been able to go across many different cultures and countries is that these elements, offsite teams that are mobile, are general enough that you can fill the staffing pattern with the people appropriate to that culture or population that you're working with. And that makes them highly adaptive. Some of the challenges that are consistent, and one of the things that Housing First programs struggle with, these are some of the challenges that have been faced all the time. We talk about the fact that Housing First programs are growing and they're international and all of that. But on balance, there are still many, many more shelter beds. For example, I recently read this brief report in Europe. There's something like across the EU, maybe an estimated 500,000 shelter beds. There are maybe 15,000 Housing First units. So in terms of the homelessness industry, we have a ways to go. We're still much more focused on emergency and transitional housing rather than permanent housing in most places. And the places that have ended homelessness have shifted that balance where they have more permanent housing available and have reduced the emergency housing. What's at the root of that? The root of systems change in most places is based on your view of what people need most urgently. And most of the emergency programs that are in place are focused on addressing the clinical problems of people first. They regard homelessness as an individual problem, a problem of addiction, or a problem of mental health, or bad choices, something that the individual brought upon themselves, and therefore the program looks to rehabilitate the person to get them ready for housing. That's what that whole staircase model is based on. And as we know from all the studies that we've done, it works for some people, but it does leave a lot of people out. And one of the reasons that Housing First programs have been disseminated is that the existing predominant model works only for about half or less than half of the people it serves, which leaves unserved, about half of the people who can't make it up the stairs or have tried and failed many times. It's very unusual to find in a Housing First program somebody that is meeting services for the first time. Most of the Housing First programs focus on people who have been homeless for a long time, and that means they've had a lot of experience with social service programs that haven't quite brought them to where they need to be. So what's another way of thinking about homelessness? And this is where you get to a more of a social justice or rights-based approach. And that there's lots of data that supports the view that homelessness is really a casualty of very poor policy and economic planning. I mean, if you just think about it for a moment, if you're assuming that homelessness is based on addiction and mental illness, why do we have a homelessness in Canada since 1990, or in the States since 1980, or in Europe, 1990? When, if it was in fact addiction and mental illness, we would have had homelessness going back to the beginning of time. There are many, many more people who have addiction and mental health problems who are housed than are homeless. So it's not an explanation that this addiction or this mental illness is creating the homelessness. We would have had homelessness earlier. Something happened in the real estate market and in the more neoliberal reduction of government and reduction of social services that created a paucity of social housing, rent supplements, wages have stagnated, real estate values have gone up. It's these macroeconomic problems that created homelessness and continue to sustain homelessness. Now, it's not black or white. Of course, these things interact, but the major explanatory variables for the existence and continued homelessness that we see today are much more structural than they are individual. I think it would be difficult to work in a Housing First program if you were focused on fixing individual problems. It would not be a good fit for you. I mean, I think you'd have to, there is a self-selecting, we're all here for a reason. And I think that you want to have staff that have a values-based approach that is consistent with the program. It makes life easier for the person working in the program, and it makes the program much easier to operate. So the, this program, what is now called Housing First, as Eric mentioned, really started as an outreach team. And the thing about, and I think that's not a well advertised fact, that Housing First, was not as much about the housing as it is about the people we serve. It's really, but it's handier to talk about it in terms of Housing First. It's a quick and easy to understand concept that you're taking the person from out of homelessness into housing. But the underlying assumptions about what that person is going through or what they're capable of, especially what they're capable of, is really the foundation of why we would even think to offer somebody the choice about what it is that they want to do. It's a view that is taken from psych rehab. The first grant that we got to work with people who are homeless and mentally ill was in partnership with the late Bill Anthony. And it was the idea that people with psychiatric disabilities, we've had it wrong, that we have mistaken the presence of psychiatric symptoms as an indication of poor judgment or an inability to make decisions for themselves. That people, because they have an addiction, can't know what they prefer. So all of this kind of fusion between psychopathology and ability to function and judgment has been ordered under a kind of a diagnostic manual that said if someone is symptomatic, they clearly can't make decisions for themselves. And I think what psychiatric rehabilitation has helped us to do is to separate the fact that many people have psychiatric symptoms, anxiety, depression, even delusions, and are still able to function quite well, cooking meals for themselves or living in their apartments or managing a life. And similarly, people who are struggling with addiction, many people struggling with addiction have full-time jobs and are managing their addiction well enough to function. And people on the street are also making decisions and choices. Their very survival, that they're able to survive through a homeless system, is an indication of their ability to make choices and decisions that are more functional than we imagined possible. Now, the approach that we took to doing street outreach changed from telling people what they're going to do to asking people what they wanted. That was a profound change for us, and it resulted in people being invited to talk about their own wishes and desires, which led us right away to Housing First, because that was the first thing people asked for. It wasn't the first thing we provided. It was the first thing people asked for. What we provided was the opportunity for them to express themselves. That's what the rehabilitation and the seeds of what we call recovery orientation is about. It's the invitation offered to people to participate in their own treatment, their own decisions at a pace that makes sense for them and is determined by them. The sequence is determined by them. The sequence of services, that is. So that's how we got to Housing First. And then it was a matter of figuring out what to do, since nobody was on the same page, and people who were running the housing programs still wanted sobriety and treatment before housing. And we had to start a whole organization to figure out how to rent housing in the community and provide the promise we had made. You know, it was step by step and a lot of trial and error, but throughout there was a consistent meeting place where we were not figuring this out on our own, meaning we, the staff, were not figuring it out on our own. We were meeting with our prospective tenants and figuring out what made sense and how are we going to put this together in a way that was safe for them and let us manage our own sense of risk of what it is to put people in housing. So we came up with this idea that they would sign the lease and be responsible for the terms and conditions of a standard lease. We would help them meet those responsibilities, but also because we're offering them a place to live while they were still using often and still symptomatic, we needed to be sure that they were okay and the rest of the people in the building were doing well. And so the other requirement of the program is that we make visits to people once they're housed. This is one of the things that's not well understood in a lot of places, because we talk also about the separation of treatment and housing. You don't have to be in treatment to get housing. That's definitely a choice, but it's not a choice not to be visited. That's a requirement, and the visit is where the relationship is built and where the negotiation for what the person wants next is planned out. But the idea that, no, I'm not going to see this person because they said, they don't want to visit anymore is not consistent with the Housing First program. The responsibility for maintaining that relationship is on the provider. It's on us. We've just housed someone who has mental illness and addiction. We need to figure out a way to have a relationship with them that's helpful and that they're going to open the door for us when we visit. That's the artful part. Even though they haven't asked for it, we want to be able to provide it. This is from psych rehab, and the emphasis on psych rehab is all about the relationship, creating a positive relationship with the caregiver, with us, so that when our tenants see us coming, they should feel the way we feel when we're about to visit our friend. That a feeling that's emotional, that's felt at the level of joy or happiness. Oh, somehow you have been able to develop a relationship with your client where they're glad to see you. That's your goal. We also have a lot of teaching and And, some people, for example, are moving into an apartment of their own for the first time ever. They've been in foster care or they've lived with family. They've never really learned to manage. So it's not, they're not doing it because of resistance. It's that people need to learn the skills and the expectations of a different set of rules and a different social norm. So a lot of that has to do with us explaining, training, teaching, and always holding out the hope that things can be better. One of the other challenges of Housing First is that once people go into an apartment, everybody relaxes, and rightfully so. It's a huge change, and people feel safer, more comfortable, they feel better, and so they they can't imagine that things could possibly be better. And it's up to us to kind of say, well, actually, it can be even better than this. Your life can be fuller than this. You can allow yourself to dream and hope in a way that you haven't before. These are two quotes from, we visit programs all over, and when we try and provide some feedback, how Housing First is this program, we talk to the program managers and the program staff and program participants. And so, it's not uncommon to hear, look, our main goal here is to keep people stably housed, keep them out of the hospital, keep them out of jail. It's one of the things that policymakers look for also. A reduction of acute care services is a big sort of policy issue. How much is this costing and how much is this saving? And that's a minimum standard. The reduction is just, for us as providers, that's expected and not really the highest goal. The highest goal for us is more like this. We're here to help people with their quality of life and do what they want to do and be what they want to be. It's a different goal than the reduction goal. It's a positive orientation. Even if program and policy has a modest goal, the actual goal of the program is higher than that. So all of that, looks like from streets to homes, but it's based on that philosophy of empowerment and recovery. So these are the 5 principles of the model. I think, in the EU, they translated the Housing First program to 8 principles because they took, for example, consumer choice. And under consumer choice, I would argue that harm reduction is under that, but they've put that into a separate thing, or they've also added person-centered planning. But these are essentially the 5 domains of the program. And under each of these are about 8 items. And that's what creates the scale of what is or what isn't a Housing First program. So I'll say a little bit about each of them. How does the program provide continuity when it's one program and the person needs all of these different kinds of services? How do you provide the additional services, and how do you create continuity of service in that context? So this is what one way. There's two things to say about that. One is that the coordination of the services goes back to the relationship. In order for the person to trust you enough to allow you to help them, that's essential to being able to refer anyone to any kind of service. People don't move on their own, and referrals don't work so well when you send someone to another program. It's much better to bring them directly and advocate for them, because referrals have a way of not working well. But the only way that you're going to be able to provide that continuity, we essentially in these Housing First programs are the glue of a system of different components. And that glue is held together by the relationship you have with the client. So it's not a passive program. This is not going in and just checking to see how the person's doing and that everything is okay, everything is quiet, we're good. That's at a minimum. The program is actively engaging and asking questions and opening doors and possibilities for people to invite them to participate and also think about creating more of a life than they had before. That's the modal housing first person, and others come in and they have plans right away in terms of re-engaging with kids, or they want to start, that makes the job easier. And because it's person-centered, you don't really know what your role is going to be with each of your clients. For some clients, you'll end up having to do a lot of the incentivizing or motivating until they feel powerful enough or capable enough to move to the next step themselves, and then you end up supporting them. So your role goes from doing almost everything in the beginning to supporting, helping, to then just encouraging the person to keep. That's the usual arc. And that's when it's going well, but you don't know how long that will take. For some people, you'll be doing support for them for a very long time because they just need that kind of support. Remember, some of the people that we're housing in these programs in the community would have 50 years ago spent their entire life in a psychiatric institution, at the Douglas. And now people are living in the community with your support. So it's already a great leap forward, but people may need support for a long time. And that's not a failure of the program. That's just people have different capabilities. And you just need to figure out what the right level of support is for the people that you're working with. Just this last point about support and engagement, you want to be active and you want to be assertive and always taking the hope and the questions to the clients, but you don't want to be coercive or pushy. There's a balance, where it's their choice versus your suggestion, and it's a tricky balance, but it's one to be mindful of. Things work better when the person is actually participating in their own recovery. This is two-sided. Okay. I thought this would be also a good place to mention in terms of assertive engagement. Another thing that's sometimes misunderstood about Housing First, which is the whole harm reduction piece of it, because often people think that of harm reduction as tolerance of drug use or just accepting that the person will use and just being okay with it as long as it's within certain parameters. That's not really what harm reduction is, any more than having someone stably housed is the goal of the program. I mean, at a minimum, you're accepting that people are using and you want to diminish the risks and the harm associated to using. But harm reduction is ideally a very active process where you are really talking to the client that you're working with about what they're using and how they're using and why they're using and who they use with. And you want to know, on a day-to-day level, what it is that is driving them to use. In the example of active harm reduction, in the second vignette here, there's a caseworker who's being quoted saying that, the person I was working with is a poly-drug use person. They use crack, they use alcohol, they smoke weed, And not all of these have the same effect on them. When they drink, that's the most difficult and challenging drug because they get rowdy, they get aggressive, they get into fights, they get hospitalized, they fall. So the drug associated with the greatest harm is alcohol. So the case manager talks about encouraging the person to smoke more weed, so rather than rely on the alcohol and look at the consequences of it. That is an example of active harm reduction where you're translating what the person is doing or using in a way that's actually minimizing the risk for them. And what strategies do you use to avoid getting into situations that you drink? And what would help you use less when you do drink? All of that. So it's not a passive acceptance of like, oh, people use and we're okay with that because we're a harm reduction program. We're a harm reduction program, which means we are looking to reduce risk, but actively also looking to help the person reduce specific behaviors that are problematic to them until they can manage in a much more effective way. So it's, I think, the identifying the specific drugs and the specific, and helping people develop specific strategies around drug alcohol use is what harm reduction really ideally looks like. The other challenging thing about these programs is that people think that case management is all about, the benefits, talking about addiction, the rent stabilization, and mental health. Those four things are very, very important, but they're not really about the life of the person. The definition that we typically have of services is too narrow to encompass the full range of things that people need in their lives. So we need to think about services when we're providing a service in a much, much broader way. When I was preparing one of these talks, my mother lives in a village in rural Greece, amazingly enough, and she has a program called Help at Home. It's a nurse and a social worker that identify in rural Greece widows or widowers that, recent widows or widowers that may need help. And even though they're living independently, they can't actually manage fully. So the program is kind of amazing. They learn about the widows because the local mayor of a village of about 700 people, so they know everyone who died, typically not many births, and who died. And so the team knocks on the door and says, we're in town, would you like us to visit you? Very proactive, they didn't even have to call for help. And so this team comes in every Friday. They're in the village. They visit about 30 widows and one widower. And I asked her, what does this team do for you? And she says, well, they definitely, the nurse checks the blood pressure and they make sure I'm taking my medication. But also, when the screen door was broken, they sewed the screen. I got a new remote. I didn't know how to use it, so they taught me how to use the remote. I needed firewood. They got that. They do whatever I need. The Greek word is otidipote, like whatever is needed, whatever it takes. And that's, to me, I think, an example of the attitude that these housing first support programs are about. It's like, but whatever it takes, whatever the person needs. We're not in there as specialists in a particular way. Our focus is that individual and what's important to them at the time. She would not sit still to take her blood pressure if the screen is still open and there are flies buzzing in and out. You have to do it in a way that makes sense to them. And why, she prepares every Friday. She looks forward to that visit So this team has successfully engaged her in a way that's meaningful to her. They understand, they have, it's that relationship. And it's all about, in my mind, about their flexibility and expansion. The social worker's not saying, I'm only here to ask you about, your family and if your kids are calling enough. And the nurse is not saying, no, I don't do screens or remotes, I just do blood pressure, So this is something that just has been recently launched in the UK, which I thought might be of interest to you. And it has to do with, it was really part of the National Health Service, and they call it social prescribing. And it's an effort to get people in the National Health Service, these are doctors, nurses, social workers, to think about services more broadly from a medical context. And it's a holistic view, and they are encouraging nurses and doctors to write prescriptions for things like cultural activities, green space gardening, debt advice, budgeting, physical activity, leisure, library memberships, education, as broad as possible. You see, and kind of helping people to think about, your support is not just this. We're actually doing a project with Tim Aubrey in Ottawa. Two organizations are participating in that will train some of the staff in this social prescribing kind of mindset to see if we can help improve the range of services that people are being offered. Okay. I think this issue of the minimum standards for housing, I think just to reiterate, really, some of it was at a minimum, and is it social? Is it rented from the community? Depends on what's available. I think underneath it all is a practical solution depending on the community that you're in. Is it scattered site or single site? There have been effective approaches using both. And one of the challenges of the program that is better addressed with the rent supplements, really, and I wanted to underline this, was the idea of the rent supplement belonging to the landlord or the rent supplement belonging to the tenant. And there is some relocation in this program. People don't necessarily succeed in the first apartment that they're in, and so it's much easier to relocate if you have a portable rent supplement that goes with the tenant, if that's available. If you're only using a social housing model, it's going to be some disruption in housing between the time somebody loses one unit and finds another. But I just say this to emphasize the fact that there's many different ways, and you just try and use the best resources you have at the time that you're operating. The choice on where to live, similarly, if you are looking for housing, there is often a managing of expectations, in what area people would like to live downtown, near the metro. But it's not, we all would. So if your rent supplement is not going to afford that, there's this invitation to choose where you want to live, but at the same time, managing expectations so that they're realistic according to the real estate market. And the other component in expanding services, I've only talked about it in terms of expanding the services to the tenant, but it's also expanding the services to the landlords, because the relationship with property management is central to the success of housing stability. Landlords are taking on a client that is much riskier than most of the clients they usually take on, and so they need the additional support from us to make that possible. The landlords need someone to call when there's an issue in housing. And I don't know how your teams are organized. Sometimes it's useful to have one person that is more the property management person than the case management person, because it's a different communication when you're trying to enforce a lease violation than when you're trying to engage and be the support person for the crisis that the person is in. Okay. So I'm going to talk a little bit about the systems change piece and how some places are implementing housing first on a broader scale. I think you all are very familiar with this. One of the things that we did learn in that at-home chez soi study is that not only was the program effective across the 5 cities where it was implemented, but it also was serving different populations. The Vancouver group was much younger than the rest of Canada, and more often substance abuse was the primary issue. In Winnipeg, so the teams also reflected that, by the way. In Winnipeg, 70% of the people that were participating in this program were Indigenous. And when we went to Winnipeg, people were not happy with the idea of a Western program model, serving the population that was on the streets of Winnipeg. And so when we talked about the staffing pattern, the community there was not interested in mental health services. They wanted to include a tribal elder from the Cree tribe as part of the staffing pattern. And half of the team was made up of people who were of Indigenous origin and had lived experience. But it was, interdisciplinary, it was mobile, it made home visits. So it had all of the structural elements of what all of the Housing First teams, but the composition was different. Toronto was, I think, about the same percentage of people who had immigrated from different cultures, primarily people from the Caribbean and all of the different islands there. And there was a immigration center and a sensitivity to the staffing pattern and needs of that community. It made housing quite challenging because people wanted to live in the community that was, in the Jamaican community, for example. There was a cluster of a few blocks, and we would wait sometimes for months for a unit to open up so people could feel they were living in the location that made sense for them. In Montreal, we learned a lot about the social housing and rental housing, the ways in which Sonia and her team were finding housing, throughout the city. It was a new initiative at that time to think about using community landlords and providing choice to people at that level. And in Moncton, there were half of the people were living in rural areas, and the challenge of using these teams in this model in a rural area was quite informative. But all this to say that when it's done well, it really, really works. This is a paper that came out of the Center for Disease Control in the United States. They did an analysis of 26 studies, and all of the studies were randomized controlled trials. Some were from here, of course, and the others were in France and some in the States. And they found, decrease of 88% overall in homelessness using housing first as we're defining it here today. So what they did also say is that the program needs improvement in the areas of recovery and improving quality of life.
Désolé, je ne vous entends pas.
I think we have really learned well how to get people housed, but we're still facing a lot of challenges in the recovery and helping people integrate back into their life. So it's not that the work is finished, but we know what direction it needs to go. And that's one of the reasons I'm emphasizing so much about the relationship and our role in the recovery, because I think we've got the housing down. It's this next piece that's going to really turn things around. I'm not sure that the reason that we talk about program fidelity just is really just what that thing, that one line there is about underlined. It's all about maximizing the outcomes for the people that we serve. And there's an understanding when you look at program fidelity that the Housing First program is not something that works in a vacuum. There's a larger system. There's other programs that don't necessarily share the same values. There's the resources, sometimes richly staffed, sometimes not. So if you're achieving a Housing First program, it's not totally about the Housing First program. It's also all of the supports or challenges that the program is facing. There is no one person who's going to define the Housing First program. When you talk to a manager, they're going to say that, this is what the program is. When you talk to somebody who's doing direct service work, they're going to define the program in a different way. And when you talk to a program participant, they're going to tell you an experience and describe a program that might be different or the same. But you have to check with every level of the program to see, is this consistently described? Are there variations? And where are those variations? And we also read the charts to see not only what people say, but what people write in their plans with the people that they're working with. And that's how we conduct these fidelity visits. And they're also useful, for those of you working in these programs, they're useful just as a self-assessment. How are we doing on these dimensions? Just to see if you're on target, drifting, what dimensions need help. Quite useful. And shown to have a very good relationship with housing stability and improved quality of life. The improved quality of life data comes from interviews rather than quantitative data. So here's what we've learned from some of the other countries. This is a paper that was recently published by Owen O'Sullivan at the Trinity College in Dublin. He compared two countries that adopted a Housing First approach in 2008. One was Ireland and one was Finland. And he chose these two, well, because they were contrasted, but also they were comparable because they were both about the same size, about 5 million people, give or take. And they both had one major city, Dublin and Helsinki. And they both nationally in 2008 committed to a 10-year plan to end homelessness. Some of you may remember that was a popular phrase about these 10-year plans to end homelessness. I never understood why it took 10 years. It really, 3 is all it should take at the most. But anyway, that was the commitment. What happened in 2008 was the markets across the world, there was a global recession. People were losing money in the market, companies closed, it was a huge economic decline, people were losing jobs, and more people were on the street than before. And what happened in Ireland was there was a lot of negative publicity about the numbers of people on the street increasing. And so the government said, well, we're going to build social housing later. Right now, what we need is a bigger shelter system. They had only 600 shelter beds across the country at that time, and they began to basically increase the number of shelter beds to get people off the street and then housing eventually. The Finns didn't balk at the recession. They stayed on plan, and what they began to do is first they legislated a plan to have a local foundation. It was called the Y Foundation, the letter Y Foundation. And if you Google them, you'll see they have an entire manual of what they did. I think it's written in English and Finnish, of course, but it's very well documented. they first allocated the national lottery money to homelessness. So all profits from the national lottery was a steady stream of funding. They began to convert, they had like 1,600, I think, shelter beds. And they began to, because it was cold, they had a much bigger shelter system. They began to convert their shelters into apartment buildings. The buildings were already there, so it was a renovation, rehabilitation. They got the Y Foundation an endowment. It's a nonprofit, right? So they got government money, they got money from the faith community, and money from the business community. They got a lot of money into this Y Foundation, and they began to buy, rehabilitate, or acquire in any way possible as much housing as they could. They would buy condos, they would buy condominiums, they would buy entire buildings, they would buy houses. What was on the market was purchased. So this is what happened. They went from 600 beds in Ireland to 2,245 beds in that 10-year period. And in Finland, they went from 558 to 52. The population of the homeless in Ireland went from 1,200 in 2008 to 5,500 in 2018. The more shelters they build, the more homeless people there were. And the homeless population in Finland went from 3,200 in 2008 to where it is today, which is 52. There's one shelter in Helsinki with 52 beds, and nobody is homeless for more than 10 days because they have now acquired some 15,000 units of housing. This Y Foundation has 15,000 units of housing. They are not renting, there's only 3,000 homeless people. They are renting it to whoever, it's a sliding scale, mixed income it's called. So if you're making 50,000, you pay this. You're making 30, 70, 0 or 10. So you pay according to your ability to pay, 30%. And it's nonprofit, so the money is reinvested into the buildings. But that housing portfolio has enough turnover that anyone falling into homelessness can easily, you get the next available unit in the place. In 2016, they introduced a prevention program because they already had been able to identify who's at risk for becoming homeless. And they identified people with psychiatric disabilities, single parents with kids that were paying 50 or 70% of their income, people aging out of foster care. And they go identify people from their rent rolls, and if they're paying more than 50 or 70% of their income towards the rent, the government supplements the rent so they don't fall into housing. So they've stopped the fall, and when people do fall, they have a way out because of this huge portfolio. In Ireland, in 2018, they just stopped building shelters, and they adopted, both the housing minister and the health minister got together and adopted a housing first model nationally. And now they're in their third year of implementing housing first across Ireland in the 9 regions. So, what does it take? It takes, if we look at Finland as an example, you need a consensus at the national level of what it is that will make sense. People have to all buy into one model. We're going to do this. We're going to house people right away, rather than continuing to fund a whole range of programs. The 2 other examples I thought might be of interest here was one in the Netherlands, where they typically use social housing. But there isn't such a big difference in the Netherlands between social housing and rental housing. There's home ownership, which accounts for about 50% of the housing in Amsterdam. And the other 50% is 25% rental owned by nonprofits. See, they don't have a big private landlord market. So the nonprofits and the social housing are much closer together than most places where private market and social housing have a much wider disparity. And what they did to address homelessness, and they're bringing their numbers down also, is that they created another stream for social housing. Typically, people used to get social housing if they were on a waiting list for like 8 years or 10 years. But if you waited that long for someone who's homeless, they would be dead. It's like it's not a model that works for this population. So they decided that each year they would look at the total number of vacancies in social housing and allocate 10% of the vacant units to people who are homeless in a Housing First program. So that allowed for a different stream into social housing and created a lot of supply where there wasn't any. Norway, similarly, they just did their last point in time count. They only count every 4 years, 99 people homeless in Norway. So they're rapidly approaching zero, and most of the 99 were in Oslo, but it's quite rural in the rest of the place. And what they've done is also commit at the national level to a program that is building more affordable housing and using a housing first approach to get people in. The federal government is lending money to municipalities to build the housing, creating the stock. So there are many, many ways to do this. It just, what's consistent in all of these is an agreement, across the board between federal or county or provincial and municipal that, it's all lined up, and an agreement about the resources and how we will do it and who we will prioritize to house. That is everywhere the same. There's a county in Milwaukee, where Milwaukee and surrounding area, it's about a 1 million population, and they just recently ended chronic homelessness. Same way, they take a housing first approach, which really looks to build more, create more permanent housing rather than emergency, removing obstacles in outreach. They had the police involved, the district attorney's office, the downtown business center, the hospitals, to identify people that were most urgently in need. They hired a group called Housing Navigators that were looking to secure available units with the rent supplements, and they had direct referrals. One of the things that they did that was very innovative was there were restrictions on who could rent. If you had an existing criminal record or violation, usually related to homelessness, you would be disqualified from eligibility for housing. And so the district attorney was on the streets doing outreach, and if somebody had an outstanding ticket or warrant, they could just adjudicate it right away and remove the fine and allow the person to move in. But there too, it was the county and the municipality working together. This example is the impact of a shelter in Boston, where the shelter provider decided they were going to use a housing first approach. It was the Pine Street Inn, biggest shelter in Boston. It's been around a very long time. This graph shows you who was using the shelter. And what you see there is at the bottom 13% were accounting for 82% of the bed nights. That means that some people go into a shelter and stay there. They're using it as a place to live. They're not moving on. And that 13% of the people, 87% of the people were using 13% of the bed nights. So people come in, they leave quickly, the shelter is functional. The people that are kind of holding things up are the people that are using the shelter instead of housing. The way that impacts a shelter and their ability to serve people, if you have people that are staying 20 nights in a shelter and then moving on, that you can refer them somewhere, or they're able to get back into housing. You can serve with a shelter of 30 beds, you can serve 548 people in 1 year. But if people are staying 6 months because there's nowhere to take them, or there's no referral allowed, that same shelter is only serving 60 people a year. So you see, if you have a system that is based on creating housing availability at more than the emergency housing, the flow out allows the existing shelter system to be much more effective and serve more people than what we're currently doing. What happened at the Pine Street Inn, the light green line shows you that when they shifted strategies and were moving the long stayers out into housing, their shelter bed numbers remained pretty much flat. They actually dropped over from 716 or 718 to 670, whereas the number of units they had per house went from 900 to 1,600 in the same amount of time. In approach and policy that has made that entire organization much more effective in ending homelessness. So it's helpful in terms of giving you a vision of what's possible. I find it encouraging. And formula seems to be going throughout for community-wide consensus, a definition of a priority population, increase access to housing, after service support, timelines and measurable goals. Most of them in like 3 to 5 years, what I'm talking about. I'm showing you data percent, but the timeline for shifting and doing things differently and getting an effect that's different than what's currently going on, it happens much more quickly than in 10 years. And it takes leadership and a sustained effort. So you come, with the idea that we're going to take people off the streets and we're going to put them into housing, and you end up, hopefully changing the entire system that's creating homelessness and housing the people that are currently there. These are recent examples of the program also being expanded to serve not only families and young people, but there's very good data for this approach being very helpful for partners of intimate violence or domestic violence partners, mostly women with children who have been reluctant to leave an abusive relationship because they don't want to go to the shelter, but they will go more quickly to an apartment of their own. So that it's another application of the model in a different context with a different group. Okay, thank you for your attention.